Today we will be covering a deep dive into challenging wounds. Firstly, in the spirit of reconciliation, we'd like to acknowledge the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respect to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples here today. My name is Caitlin Roberts and I'm the Product Manager at Team Medical Supplies. At Team Medical, we're committed to providing quality education to support you in practice. Today's webinar topic is challenging wounds. Thanks to our partners Hartmann for making today's webinar possible. I would just take a few more moments of your time to cover some housekeeping before handing over to our presenter, Hayley. First off, it's great to see so many of you joining us today. For all participants, cameras and microphones are turned off and muted. However, we do encourage your participation via the chat box. To make sure it works for you, please open the chat now and say a quick hi and where you are dialing in from. We will be having some Q&A throughout as well, some chances for you to give some feedback throughout. So please test your chat now so that we can get those answers from you. As mentioned earlier, this webinar is being recorded and we will share a link with you tomorrow. Our link will also be added to our events webpage. Our speaker will share an informative presentation, then there will be a formal Q&A session at the end. Please write your questions in the chat during the presentation. Our marketing team will reply to any general/tech questions and gather questions for our speaker Hayley to answer during the Q&A. At the end of the session, we will share a survey link for you to click and reply before continuing with your evening. We ask that you please take a minute or two to fill this out. This allows us to continue improving our webinars and deliver relevant content for you and those joining us next time. Today, our expert speaker is Hayley Ryan from Wound Rescue. Hayley has over 20 years of experience in nursing and a passion for healing wounds. Hayley is the Director of Wound Rescue and also the Chair of the Board of Wounds Australia, just to name a few of Hayley's roles. Thanks, Hayley, for being here today. Following Hayley's presentation, we'll take a closer look at some wound care products from Hartmann and then dive into the Q&A. I'll now pass over to you, Hayley.
Thank you so much, Caitlin, and welcome everybody. A huge thank you to Team Medical and for Hartmann for asking me to come along today. My brief was simple, to look at a deep dive into challenging wounds. Now, I think you'd agree that is not simple, but we're going to give it our best. And the way we're going to actually do this today is by interaction. So hit those buttons on your chat system, like Caitlin just said, and let's get involved. Just a quick disclaimer, you are going to see wound photos. I know I start all my talks that way, but they can be a little bit frightening for some people, so be mindful of that. I do have permission to use the photos. They are patients of mine, and I have permission to tell their stories. Also, a disclaimer, Hartmann is supporting me today as well as Team Medical. So what are our learning outcomes today? I want to go through what actually is a hard-to-heal wound. And why are they so hard to heal? I want to touch on the economic burden and how can we better manage wounds. And we're going to do this together tonight. So let's see how we go, because tonight will be very interactive. I want to first stop, pause and have a think about what we know in the current literature. And this is what the research tells us, that typical challenges in hard to heal wounds are related to often infections, which can delay wounds from healing, chronic conditions and non-concordance. We know that sometimes with our best intentions to put the appropriate treatment on a patient, they may not want to comply. And I've certainly got compression on the screen because we know often our patients don't want to wear compression for a variety of reasons. Poor blood circulation, decreased oxygen and nutrients, and immune cells can actually hinder a wound from healing. They have to be functioning in the right space at the right time. And the biggest one that I've found within the literature in large systematic reviews is that often misdiagnosed wounds is a big problem, which can then lead to inappropriate treatment. So what is this notion of hard to heal wounds? Well, in fact, We've called for many, many years now wounds that don't heal a chronic wound. We're now changing our language, and we're now calling wounds that don't heal in an ordinary time frame hard to heal. So what is a hard to heal wound? It's simply one that fails to heal with the standard therapy in an orderly and timely manner. This applies both equally to both acute and chronic wounds and is independent of the wound type or etiology. So before hard to heal wounds came about, chronic wounds we would know are wounds that don't heal within 4 to 6 weeks. But now we know even acute wounds, even complex wounds where maybe a patient has things like diabetes in their diagnosis, or perhaps they have an infection, making that wound a complex wound, that there can be delays and therefore they become hard to heal. We obviously always know, and we always revert back to what you can see on your left-hand side, which is the phases of healing. And we still know to this day that often when a wound is stuck in healing, it's often in this phase, the inflammation phase. And that's where we need to come in and kick it into gear to keep it healing through to proliferation and that remodeling. And remember, the remodeling phase can take a couple of years as that scar tissue forms. Now, I'm sure you've heard this over and over again. What is the actual burden when it comes to wound management? We know that in Australia, around 450,000 people are living with a wound at any time. In fact, it's around the same number as people living with dementia. So that should give you an idea of how severe this issue is with wound care. It costs us around $3 billion to treat a wound, and it's around 2% of the overall health expenditure. The issue here is that this is just an estimate. We believe that it's a lot higher than that, but because we don't collect data in any such database, we can't get true figures. So our best estimations are around 450,000. So the question is, how can we as clinicians, and I'm sure you're all clinicians on the line today, how can we better manage these very difficult or hard to heal wounds? Well, we have to switch our thinking and go back to the principles of wound management. And here's what the literature tells us, that when you're thinking about how to heal a wound, you should be asking yourself, have you asked that person how they got the wound? So identify the cause of the wound. We always talk about holistic health assessment as clinicians, but do we actually meet that brief? We then can look at the wound and assess that wound. And notice I didn't mention wound until the third item into the principles here. We do want to adjust the care regime to meet the response. What we know is that if we've been using the same product line for 2 weeks and nothing's changing, it's stagnant, and we've tried everything in our power, including good nutrition, then it's time to change the product. It's not working for you. Always consider the goal of care. Is it, and it's not always about, is the person palliative? Are we just going to treat conservatively? But what about things like what's important to that person for the next month? Maybe it's so that the person can go back down to the shops comfortably without a dressing seeping through with exudate. And of course, infection control. And then we come to, once we understand these simple principles, we come to the 3 elements that will heal your wound. And this again is clearly in the literature. We know that if your patients have good amounts of nutrition, good amount of water, and the appropriate amount of oxygen, we're going to get somewhere with healing those wounds in a timely manner. But I think it's fair to say we all know that often our patients are not able to achieve good diets all the time or good amount of fluid. And remember, if somebody has a lot of exudate coming out of their wound, they need a higher level of fluid going in because they're losing fluid. And oxygen is critical. So if you think about some of your patients, they may have COPD, emphysema, bronchitis, all of those elements that are respiratory related will have a deficit in oxygen. Now, understanding those principles and the key elements to heal a wound, the other element to help you in the path to healing wounds is to think about what approach do you take when you look at a wound or when you look at the person. Now, I tend to use Heidi. I find Heidi over the last 22 years of my working career to be a mnemonic that resonates with me. I'm sure you've heard of others out there and you are welcome to use whatever you like. I just like Heidi simply because it's the only one I feel really looks at the person holistically. Now, what Heidi stands for is history, examination, investigation, diagnosis, and implementation. If you have a phone on you now, you may want to take a photo of this screen as we get through to working together throughout this talk tonight. So when it comes to history, you want to consider what's the person's family history? What's their past history? What surgery have they had before? What are their comorbidities? And I'm sure you would know things like diabetes is really important to know. I've just demonstrated that oxygen is an issue. So do they have any respiratory issues, cardiac issues? What medications are they on? Another crucial element. We know that certain medications will delay wounds from healing. And a few off the top of my head: cytotoxic medication, steroids, anticoagulants. We know that the health behaviors, so non-concordance or not wanting to stick to the plan for whatever reason, will delay a wound. Pain is important. We need to be asking the question at every dressing change: do you have any pain as you're taking the dressing off, whilst the dressing's off, and when you're applying it, and when they're just sitting there during their normal day? And what's their overall quality of life? Of course, then you also want to think about nutrition. Now, once you've gone through that history, it's now a good time to look at the wound and consider the history of the wound. How long have they had it? What previous wounds have they had? What previous treatments? If it's an ulcer, how long has it been since their last presentation of an ulcer? Because what we know is that around 80% of all ulcers will come back if we don't apply compression garments. And allergies is crucial. So that's the H under Heidi, that's the history. Then you can move on to examining the person. And I'm not just talking about the wound, the actual person, a head to toe thorough assessment. It tells you a lot about the person. Do they have dry skin? Do they have peripheries that are quite cold? Do they have, areas of blotching on the lower legs? All crucial to developing your plan. And then you want to start to think, I have an idea what type of wound this is, but I want to do more investigations. So what other diagnostics do you need? Whether it be an X-ray to look at osteomyelitis or blood results, or perhaps a Doppler. These are crucial because now you can get down to the nitty-gritty and what is your diagnosis of the wound? Because by knowing that, the final part of this is implementing a plan. And if you've gone through that Heidi process, it helps you get to what you need to do now. So I'm hoping that that structured approach is helpful to you in your everyday practice. I would encourage you to use this or other mnemonics that you're already using. But we're going to apply a little bit of this now. And I've been asked to present on case studies this evening. So I'm going to kick off with case studies in the term of pressure injuries. We're going to start here. We'll go through some other etiologies, but we'll start with pressure injuries. The first thing I'm going to draw to your attention is that we do use the National Pressure Injury Advisory Panel staging system. This allows us to have 6 stages of pressure injury. Stage 1, which is red and doesn't go away. Stage 2, it's red and the skin's broken down. Stage 3, we've got layers of the skin have gone and we can start to see fatty tissue. Stage 4 is where we have full thickness tissue loss and you may see bone, tendon or muscle. Unstageable pressure injuries, they're called unstageable because you can't stage them because they're either covered with necrotic skin or they may be covered with thick tenacious slough. And suspected deep tissue injury, where it's that maroon filled blister or maroon colouring. Now, take a look at my screen, and what the NPIAP have done so well is they've also catered for those with darkened skin tones. And it's really important because have a look again at my screen and take a look at stage 1, for example. Now, when I show you the darker skin tone, have a look at how different that actually looks. So this is why we need to factor in what we're looking at for different coloured skin tones. If you want to get copies of these, you can go to the 2019 guidelines for pressure injuries. So what I'd like to do now is take you through the entire process of Heidi and seeing a patient. So this is a case in review, and this is where you're going to have to really tune in, maybe take some notes, maybe take photos of the screen, whatever it is, because you're going to be needing to answer some questions. So here's our first patient, and her history is a 72-year-old lady living with rheumatoid arthritis, atrial fibrillation, limited mobility, so she's actually bed and chair bound and requires a lifter. Her pain is 6 out of 10. She lives in a residential aged care home. Her diet is okay, and unfortunately she is unable to communicate. Her medications of significance to wound healing is that she's taking methotrexate, which is a low-dose cytotoxic, and warfarin, as we know, is an anticoagulant. Now, the wound was first noted on return from hospital for an upper respiratory tract infection in December 22. So she went over to hospital for an infection on her chest and came back, unfortunately, with a pressure injury to the aged care home. She has 2 daughters, both general practitioners, and she has a son who's an engineer. One daughter visits regularly and is listed as the person responsible. No allergies. Moving over to the examination, the wound is a non-blanchable erythema of intact skin with localized redness to the buttocks. On investigation, she did have a high Waterlow score, which indicates to us she's at high risk for pressure injuries. She did have pain, and the nurse unit manager from the hospital noted that they hadn't applied a pressure injury device. The overall diagnosis of this wound was a stage 1 pressure injury. So this is the wound, December 2nd, 2022. So taking a look at the history there and taking a look at this wound, my question is simple, and it's your decision to make. Was this pressure injury avoidable? Drop it into the chat, yes or no. And I'm going to get one of my colleagues from Team Med to give me the answers because I can't see them.
There's lots of yeses coming in, Hayley.
Okay, let's move it on and we'll continue through this patient's journey. So there were a number of contributing factors here. Firstly, there was no offloading device initiated. Pressure area care, was it made a priority? We're unsure. There were changes with staffing levels, and think about your own practice. How many times do you have to hand over to somebody and they hand over to somebody, and things can get missed? There was an inability to independently mobilise because the patient wasn't able to do that due to her comorbidities. And the wound was first noticed in December 2022. However, no dressings or interventions were implemented until the end of December. So by this stage, by the end of December, when she's returned back to the aged care home, this is the wound. So I have the same question for you all. Is this avoidable? Yes or no? We're getting some yeses or nos, my Team Med friends.
We're getting some yeses and some thumbs up. So
And
I'm
some
assuming
thumbs
those are also yeses.
I
that
hope
works
so.
as well.
Great. So let's have another look at the journey of this patient and you'll see what one person has gone through. Now, she's had to return to hospital in January. So remember, she had that stage 3 pressure injury by this stage. And by January the 10th, 2023, so only a month later, this is now the wound. When she's returned back home to the aged care home on January 28th, so by the end of the month, this is now the wound. So as you can see, there has been some significant changes to that wound bed. There were a number of contributing factors. There was non-concordance of the patient. In fact, she didn't want to offload the pressure, despite all efforts of the hospital and the aged care home. The alternating mattress was in place. However, on inspection, someone had actually inadvertently turned the static off. My tip to you all is always check your alternating mattresses. The residential aged care home had only basic dressings. In fact, the dressings they were applying was Melalite and Mefix. And the nurses did not initiate a referral to the specialist, despite it actually being within their policy. And the hospital then initiated simple saline-soaked gauze. Now, I want to ask you, what more would you do? Drop it in the chat. What else could you have done for this patient to avoid this person from getting to a stage 4? Remember, her journey started as a stage 1. Give me some other suggestions of what you could do personally, as a group within your service that you work at or hospital, and what other suggestions you have. And I'll get one of my team medical friends to tell me some of the answers.
We have reposition to hourly, pressure area care to hourly, skin care, preventative silicone dressings, dietitian physio education, lots of pain relief, correct dressing choices.
Amazing. All amazing.
Border dressing, high protein fluids, wound nurse.
Yes,
proper
yes,
assessment.
Brilliant. I'll stop you.
Lots.
And that's exactly what I want to hear. I want to see this thing light up, because they were amazing suggestions. It wasn't just, and I didn't hear anyone just say, put a dressing on this. What I heard was early intervention, education, dietitian, all of those wonderful things. So we did intervene and we did provide education. We talked about preventative strategies, support services, dressing choice. We even spoke with procurement around what resources were available for the aged care home, not just simple dressings, and early referral. And how can we better, as an aged care home and the hospital, collaborate more freely? And of course, the referral was received. Now, we did initially commence negative pressure wound therapy because we really needed to clean that wound up, and it was rather deep. And then we actually switched over to the HydroCleans. And as you can see on the screen, we now have a cleaner wound bed. It's not looking as concerning as it was, and it will now be on track to healing. So in terms of key learnings, there was a lack of clear communication between the acute care and long-term setting. There was non-concordance, but here's my tip to you all. Often we say that the patient doesn't want to do a certain thing, in this case, reposition, but has anyone actually asked why? So when we actually asked the patient, why won't you stay off your side? What we found out was the pain that she had was all in her lower lumbar region, and that's from her rheumatoid arthritis, which caused her not to want to move any other way but to lay on that area. Late referrals are often a huge impact, so find a wound specialist in your area and get to be their friends very quickly. There is a lack of focus sometimes on resources, and what we often see is that the focus is more on the costs, and we understand we've got budgets to manage, but when you weigh up what you just seen with this patient, you sometimes have to wonder, should we have waited? And we did hold case conferences, which also closed the gap of that collaboration, and of course, ongoing education. My final question for this patient, was this avoidable? I think I know your answer. If you've said yes, you are spot on. Now, when it comes to actual these types of wounds, pressure injuries, there are certain risk factors. So there is pressure, so impaired mobility, as this patient had, impaired activity, impaired sensory perception. And then if you go over to the tissue tolerance, you have two areas. You have extrinsic factors, moisture, shear, and friction. We know they're the three things that will cause a pressure injury, and intrinsic. So it was so great to hear somebody say nutrition and a dietitian, demographics, oxygen, skin temperature, and chronic illness. There are also some medical risk factors. So if we think about a disease process, perhaps the patient has dementia, or maybe a stroke and Parkinson's, or unrepaired hip fractures, frailty or sepsis, heart failure, calcium channel antagonists and alpha blockers. These are things that can also cause or heighten the risk of a pressure injury. Etiologies such as hypomania, mobility, contractures. Think about those patients with contractures, mobility, tone, nutrition, localized edema. And there are interventions. We do want to avoid over-sedation, and I know that we are moving more to preventing that as best we can. Dopamine, advocate repair and assessment of fractures, treat underlying causes, diuretics to some degree, particularly with fluid retention, and avoid and cease offending medications if able. The other thing that I would bring to your attention is, do you know where to get the most evidence-based practice when it comes to pressure injuries? So 3 documents I'd suggest you get your hands on is the application of aseptic technique through Wounds Australia, and you can get that from their website. A wonderful book on nutrition and wound healing, and that is through Nestle. And as I've already said, the wonderful 2019 pressure injury guidelines. Okay, we're going to do this another quick case in review, and this one's a bit quicker, but it's a very interesting case. So really try and listen to the detail for this patient. This is an 89-year-old living with non-insulin dependent diabetes, osteoarthritis, ischemic heart disease, breast cancer, bed and chair bound also. Pain reported by the patient is only 2 out of 10. Lives in her own home. Diet is okay. Noted a deterioration in overall health over the last 6 months and is now noted as palliating. The GP has in fact charted the crisis medication, but they've not yet been fully implemented. Medications of concern is for wound healing is morphine, the haloperidol, which wasn't commenced as yet, and the midazoline. Now, the wound for this patient was first seen by the visiting home and community nurse in mid-23, and the person who actually looks after this patient is the husband and the daughter. They're the primary carers, and they live in the home with the patient. No allergies. Again, this was a localized area of redness, maroon in color, to the right hip, and that's key, guys, to the right hip. On investigation, another high risk for pressure injuries. Pain was hard to determine because she was taking the morphine, and it did appear that this wound came up very quickly. There's a clue, guys. This wound came up within 24 to 48 hours. And I will say that the family take an extraordinarily proactive approach to reviewing her skin every 2 to 3 hours, every 2 to 3 times a day, and they are very focused on picking up any changes to her skin tone. But the patient actually preferred to sleep on her left side, and remember, this wound's on her right side. The initial diagnosis was a suspected deep tissue injury. So this is the wound. So in June 2023, this is the wound. My question to you is the same. Was this avoidable? And Caitlin, if you could let me know.
Yes, is my first answer I have here.
Ooh,
few more
we got
yeses.
some. Excellent.
Yes, yes, yes.
Okay.
Yes.
Good. We've got some interaction.
One no.
I like it. Oh, one no. I'd love to hear
maybe,
why.
and maybe not.
Okay. Great.
Another no.
Okay. For those that are writing no, I'd love for you to put in the chat as to why you think it's not avoidable. Now, there are contributing factors here. Obviously, the increase in need for morphine. Nursing care, in fact, was not 24/7 because this patient lives at home with her daughter and her husband, who are her carers, and the home and community services only came in a few times a week. And this patient couldn't move herself. She was on an end-of-life pathway. She did have an alternating mattress in place, and it did have all the correct settings. She did have the appropriate dressings in place. And there was, however, a delay in increasing the home and community package because we all know how difficult it is to sometimes get that moving. So this is now the wound 11 days later. And as you can see, there is a significant change now to this wound on the hip. And now take a look only 31 days later. Again, you can see the massive deterioration. In terms of interventions, education was given to the caregivers, which happened to be the daughter and the husband. The GP really tried hard to increase the package for the home and community nurses to go in. The end-of-life pathway, including the crisis medications, have now been commenced because she had actually deteriorated. Now, what I will say, the key learnings here is that the family can be wonderful allies in care initiatives, and some pressure injuries can develop quickly and need to be considered in the context of end-of-life pathways. Is it a pressure injury or is it another type of etiology? So my final question for this patient, was this wound avoidable? And if you're writing no, give me your reasons. We got some answers.
Yes, yes, no, yes, yes, yes.
Okay.
No, some sort of cancer is one of the reasons.
Okay. I like
one
your
of the
thinking.
reasons.
Yep, I like your thinking.
No, a type form of gangrene. Hornia's gangrene.
Yep.
Due to approaching end of life care, skin is failing.
Love it. I'm going to stop you there because that person is spot on. In actual fact, this is what we now know as a Kennedy terminal ulcer. This is an ulcer that some people can develop when they're dying. What it in fact looks like often is on the sacrum. It can be shaped like a pear, butterfly, or horseshoe. It can have different colors of red, yellow, black, or purple. The borders of the ulcer are usually irregular. The biggest clue for a Kennedy ulcer is they have sudden onset. And I just described with this patient, this wound turned up within 24 to 48 hours initially. Some of the statements I often hear is, oh my gosh, that wasn't there just the other day, or I worked Friday, I came back Monday, and now they've got this horrible looking wound. If they are end of life, this could be leading you down the path of a Kennedy terminal ulcer. So what is the treatment? It's essentially the same as any other pressure ulcer or pressure injury. What causes it? In actual fact, what we've been led to believe is that the blood perfusion is an issue, and this is exacerbated by the dying process. And it's what that person just said on the chat. It is multi-organ failure. As we are dying, our organs close down, and the skin is the largest organ on the body. So some of my key messages to you all is that this does not occur from a lack of care. It is unlikely to heal because it's about end-of-life organ failure, and therefore it can be unavoidable. So a difference of thinking if we were thinking that this was a pressure injury. Two different wounds, but you can see how we can get the etiologies wrong. I'm going to now flip over to lower leg ulcers, and I'm going to do a little bit of detail around what is a lower leg ulcer. It is essentially full thickness skin loss, and it can be due to any cause, but often there are underlying disease processes. For example, if we think about venous insufficiency within our veins, we have those valves, and those valves become non-functioning. In other words, they do not close properly. And when they don't close properly, the fluid can start to pool. And the reason I have on your right the little calf muscle picture there is because it's our calf muscles that actually keep that muscle pump going to push that fluid back up. And these valves, if functioning properly, will close and stop the pooling. Now, how do we progress to a venous ulcer? We get those incompetent valves, as I've just explained. We get that venous stasis pooling. We get exacerbations of high pressure, venous dilation, tissue flooding, intoxication and local ischemia, and then we end with a venous ulcer. If we think about the other main type, and I will say venous ulcers are around 65% of the time that you're looking at an ulcer, they will be venous insufficiency. If we switch now over to arterial insufficiency, this is where we have the calcification inside the arteries. And so what happens is we get a reduction of the blood flow here because of that plaque buildup. And that's how we can lead down the path of arterial insufficiency. So you as clinicians, what you're looking for is the characteristics of the wound. So for example, if you're looking at a wound, and I'll start with venous ulcers, they tend to happen within the gaiter region, below the knee and above the ankle. They tend to be really jagged around the edges, and they have copious amounts of exudate. If you think about an arterial ulcer, they're a little bit different. They tend to occur from the ankle down to the foot. They're quite circular, and they have what we know as a punched out look. As you can see in this photo down the end here, this is the punched out look. So let's now do a case in review. And again, I will start with Heidi. This is a 71-year-old, overweight, smoker, poor diet. The wounds have been here for over 3 years. The issue with this wound is that there's been multiple infections landing this patient in hospital several times during the year. There's copious of exudate. It is malodorous. There's lots of edema. Pulses, however, are okay. The swab was okay. And the initial diagnosis by the clinician was simply lower leg ulcer, but we didn't know what type. The dressings was a paraffin gauze, absorbent dressing, and a crepe bandage. This is the wound on the 1st of September 2022. Remember, basic dressings were applied: paraffin gauze, an absorbent dressing, and a crepe bandage. And the wound continued to deteriorate. Now, take a look at the edges. You can see all of that maceration, as you can see by the white. Okay, I want to know from you, what was missing in that case? What could you have done to get to a proper diagnosis and work out what's the next steps? Drop it in the chat for me. Got anything coming in, Caitlin?
Doppler compression, Doppler study compression, biopsy, ABPI, which Doppler, knees drying out, Inadine, Doppler, further investigation, diet, X-ray, ultrasound.
Excellent. Excellent. I'll stop you there. This is way on the right track. Well done to these clinicians that are here tonight. That is spot on. And guess what my first one is? Doppler, Doppler, Doppler. We should be with any lower leg wounds. If we've got concerns and we are thinking that it may be venous insufficiency, get that Doppler, whether it be a toe pressure index or an ankle brachial pressure index. Then that will lead you down the path of what's your diagnosis. Is it venous or arterial insufficiency? Which then will lead you down the path of what dressing do I put on? Do I actually consider using a compression bandaging? So this wound, yes, we did actually alter to a silver dressing, a Zetravert Plus, and compression bandaging. And that is because we did our due diligence and did a Doppler TPI. And so now what you can see on the 5th of October, and remember this patient's had this wound for over 22 years, but you can now see, sorry, not 22 years, that's the year. She's had this wound for over 3 years. And in 2022, in October, you can see a massive reduction. The exudate, however, remains in some parts. But by the end of October, the anterior wound is completely healed. The lateral wound still remains. The exudates decrease. We've got epithelialization, as you can see here as well. And by November, we're on track. By the end of November, we're pretty much healed. So that is a really good result for this patient who's had this horrendous wound for over 3 years. Of course, there was challenges, and the challenges were of managing that exudate. And the bonus, however, was because we put the right dressing on at the right time, we actually stopped this patient going back and forward to hospital because of these infections. So if you are considering that you have a patient with a venous ulcer, this is what the literature is clear about, that the gold standard care is compression therapy. If there's no contraindications, should be applied as quickly as possible if you've done your due diligence. And hot off the press, recently released, here are the guidelines that you can access free of charge. We've just finished writing these. I happen to do the compression chapter with Professor Pross from Europe, and these are the lower leg ulcer diagnosis and principles of treatment guidelines. So you can Google that, it will come up, you can download it free of charge, and you've got it in your hot little hands to best guide your practice. So we made it to the end, and my take-home messages are for you that wounds can fail for multiple reasons, making them a challenge. Non-concordance, the person's age, and infection can certainly be contributors. We do want to protect the skin as the first line of defense, and we want to avoid infections by managing the bacterial load, prepping the wound for success, and consider antimicrobial dressings. There's my references, and anyone who would like to get in touch with me, scan the QR code. And with that, I'm going to thank you very much, and I will hand back over to you, Caitlin.
Thank you, Hayley. I'm sure everybody will agree that that was very informative. In a few moments, we will dive into the Q&A, so please keep on posting your questions into the chat, and we'll jump into that in a few minutes. Hayley, would you mind just jumping to the next slide for me? So I'll just quickly now run through 3 key products from Hartmann, who is our sponsor tonight. Thank you very much to them for making this webinar possible. The first one, and likely one you are familiar with, is ZFit Plus. That's the one on the left. This is Hartmann's super absorbent polymer containing dressing, or an SAP that you might know it as. This product offers excellent absorption and retention capacity, and is a commonly used super absorbent dressing used in highly exuding wounds. ZFit Plus offers reliable prevention of leakage and strike-through support. It improves wound healing through proven reduction of maceration and absorption of excess wound inhibitors. And did you know that a 10 by 10 centimeter size dressing can absorb 189 milliliters of fluid and hold on to that fluid even under pressure? It does require a bandage to keep it in place, and a popular choice is Peerhaft, which is also from Hartmann. Peerhaft is a conformable, breathable, self-adhering bandage. ZFit Plus comes in a variety of different sizes to meet all needs. The next dressing is ZFit Plus Silicone Border. To put it simply, this is ZFit Plus with the added feature of a silicone wound contact layer. The contact layer allows for almost painless dressing changes. It's also available without a border. The version with the border, the border is transparent, allowing you to visualize the peri-wound. The border also has the added bonus of providing a water and bacteria-proof barrier. The ZFit Plus range are comfortable to wear and offer very good absorption and retention whilst maintaining the optimum wound microclimate. According to the Union of Wound Healing Societies, super absorbent polymer dressings are versatile with a growing use in exuding wounds. Essentially, they optimize wound healing moisture levels, protect the surrounding skin, manage symptoms, and improve quality of life. The final dressing tonight, and another one that Hayley has mentioned early in her presentation, is HydroClean. Think of this one as a washing machine for the wound. It rinses, cleanses, and absorbs in one mechanism. It supports autolytic debridement, reduces bacterial load and biofilm, and supports granulation by inactivating the excess wound inhibitors. It's easy to remove, and it also has silicone strips to provide an extra level of comfort when in place. HydroClean is impregnated with Ringer solution. The Ringer solution provides some pain relief because it soaks exposed nerve endings. HydroClean is also available in a range of different sizes to suit different wounds. It does require a secondary dressing, so consider something from the ZFit Plus range. Where you need to remove devitalized tissue, consider HydroClean. Hayley, would you mind just jumping to the next slide, please? The other thing I would quickly mention is that Hartmann do also have a wound care app that has recently gone through an update. It has a lot of wound care information on their dressings. And it also has a dressing selection guide where you can look at different types of wounds, and it will give you some suggestions. If you'd like to download it, you can scan the QR code on the screen now, and we'll also include a link in the email that we send tomorrow if you'd like to download it. Okay, that's it. So I think we can dive into the Q&A. Let's pull this up. Would you mind just repeating what dressings you would have used for that leg ulcer?
What I used? So yes. So we used a silver dressing that was a gelling fiber. So firstly, the issue was the patient actually had a lot of infections. So you needed the antimicrobial to try and stop those infections, but also you needed a product that was going to soak up the fluid and wick it away from the actual wound bed. So we used a gelling fiber that had silver impregnated in it. We then applied a Zetravit Plus because of the amount of exudate. We needed that stronger absorbency, and we did use actual compression for that wound as well.
Okay. What would you use if silver was not tolerated?
Yep, so another antimicrobial. There's plenty on the market. You'd have to weigh it up. For this particular one, what makes it tricky is the fact that it's got a lot of fluid there. So, you know, you might say, oh, I might go for a cadexamare iodine, for example, or another type of a medical grade honey. But the problem is they're a wet product. So you'd want to get another type. Is it an alginate product? Something else, again, that's going to soak it up. And it may not have silver in it, but at least it's going to try and manage some of that fluid. If I may say too, I'm talking about primary dressings here, but the real focus comes down to really good wound hygiene. So using products that will scrub, you know, using those microfiber cloths, not the ones you buy from the store, things like the medical grade debris soft, for example, and giving that wound a really good scrub to wick away some of that tenacious slough. Now, I did see a pop-up of Counterstat. Whilst I don't usually talk to brands, what I will say about Catastat, it is very good at managing bleeding, but for wound care, it tends to leave filaments in the wound. So we try not to use it on those type of wounds, and certainly not in cavities.
Okay, that's great. Why not chemical debridement was one of the questions there.
So you could use chemical debridement, but I always weigh up the patient. Again, looking at the person holistically, I find that often chemicals can actually cause a lot of stinging. Having said that, I would use products like oxidized solutions, like microdacin solution, that is going to provide that oxidized level that's at a suitable pace that's not going to sting the person. It's all about knowing your patient, and you may have some that are okay with that.
What about a hydrocolloid dressing to debride the wound?
Oh, okay. So no, I wouldn't use a hydrocolloid on that wound, because it's not only going to bring up the gunk and whatnot, but it's probably going to take away the good layer of skin as well. They're too adhesive. They do stick to the wound, and in fact, they're known to actually harvest bacteria and increase potential infections.
Yeah. Some more info on HydroClean. Are you able to give some more info on how you would use that or have used that in the past?
Yep, I've used HydroClean for many, many years. It used to be another name which escapes me at the minute. Do you know, Caitlin? I've gone totally blank. Tender wets.
Yeah.
Many, many, many years ago. I'm talking 20 years ago. They used to be Tender Wets, and now they've renamed to HydroClean. I don't work for the company, so I can't talk about their products, but what I can say is in clinical practice, how we would use them is exactly what Caitlin said. And I like that the talk was about, it's like a washing machine. So you put it on, and the Ringer solution constantly washes out and pulls away that tenacious slough so that you can clean it up and get to that wound bed that you want to see, that granulating tissue, to focus on actually healing that wound.
Are hydrogel products of use with leg ulcers?
Again, yes and no. So one of the things I always teach is when you're looking at a wound, don't think about the product. This product will go on this type of wound, or this product will go on that type of wound. Look at each wound individually and consider what are the characteristics. Now, for example, that leg ulcer that I showed you that had so much fluid there, you could see how wet that was. A hydrogel is not going to help at all. It's probably just going to float off. It's too wet. So you need to dry it up. Having said that, if I had a wound that was extraordinarily dry and I needed to moisten it a bit, I might apply a hydrogel.
Great. Another question we had was, in Queensland, it's very difficult to get pressure garments to be worn. Do you have any tips for that?
Yes, Queensland, some of my patients in the Northern Territory, particularly in Alice Springs, and my patients in top end Queensland, all have issues wearing, and my patients in Western Australia have issues because of the heat, right? It's uncomfortable for them. So there's a couple of things we talk about is what we know is when we talk about compression bandaging, the gold standard is what we call 40 millimeters of mercury. That's the pressure you want to get to actually aim for healing capacity in a reasonable time. Our patients won't always wear that tight. So what I do is kind of a tiered approach. What I generally start a patient in is things like a layer of tubi grip. Then I might move them up to light compression. And then I move them up to the 40 millimeters or they're close to of mercury for that compression. And I get far more tolerance, whether it's in a heat affected area where it is really humid as well, by doing that slowed approach. Now, of course, every patient's going to be different, and we do find a lot of patients still don't like it. I have to say, turning to things like the Farrow wraps, where you can actually use the Velcroed wraps, also can help because the patient can take it off if they need a bit of a break. Hopefully that helps.
Yeah. We have a question here about patients often showering when told not to. Are any of these bandages or dressing safe to use when in the showering, or just basically if you could provide some tips on what to do with patients who aren't compliant with when it comes to showering?
Great question. I get it probably 100 times a day, and I probably don't have the best answers for you. But what I'll start with is that no product is waterproof. I would consider products water resistant. And what I mean by that is if you're going to sit in a bath with a dressing, or if you're going to hold it under the shower, it is probably going to get some water in it. And that's the worst possible scenario, because if you've got water trapped under it and you don't pick it up and you leave that dressing on and it's not due to be changed for 3 days, that bacteria is growing and swimming around and having a party. And when you come along, you've got to really look at, do you have an infection or is there a potential risk here? Some suggestions, there are products you can buy from the pharmacy, and actually I think Team Medical's got some too, where they're like a plastic boot that you put over the leg or the limb, which goes over the top of the actual dressing, and it stops it from getting wet. Or, you know, we go back to our practicalities and we use a couple of layers of plastic bags and tape them on. There's no easy answer for this because it can be a challenge.
Absolutely. How is hypergranulation best managed?
Yep. Hypergranulation, I tend to use, again, a bit of a tiered process before you go grabbing your silver nitrate sticks, which can be a bit painful to the patient. First thing to do is start with a bit of foam and a bit of pressure. So foam and a bandage, and try that for a couple of days and see if that is able to bring it down. If that's not working, consider a silver dressing. That can sometimes wick it away. If that doesn't work, sometimes you do need to go back to the silver nitrite sticks.
Absolutely. Cost is something that can also hinder wound healing. Patients state that they can't afford dressings and try to treat the wounds themselves, which in turn leads to heinous wounds. Any tips there that you can
This
provide?
is the sad reality. And if I put my Wounds Australia hat on, if you're not a member, please become one, because this is what we are advocating for. If anyone listens to politicians, you would have heard in the recent federal election that $48 million, after all the hard work that Wounds Australia has done, has been awarded for a consumable scheme. And what that means is they're going to actually fund now some of these products for a specific group of patients. Those patients will be anyone over the age of 65 living with diabetes and a wound, and any First Nations patient over 50 years old living with a wound. And that won't come into effect till next year, but Wounds Australia will work with our government bodies for that.
Okay. I have another question here. I would love to learn more in depth on wounds. Is there further training available? Which I think
Well,
we can.
nice
Yeah.
synergy. So, you want me to announce it? I can announce it.
So, go for it. Sorry.
We're currently, I've partnered with Team Medical, and we are travelling all over the country, and we're delivering our masterclasses with Wound Rescue, my company, and Team Medical. So our next sessions happen to be in Sydney. We've recently been in Brisbane and Gold Coast, and now we're heading to Sydney. So if you are interested in attending, scan that QR code. Geez, we're overwhelming them with QR codes tonight, but scan the QR code, get your ticket, get in early, because can I tell you, these sessions really do run out. So if you want to be involved, make sure you book in.
Awesome. Yeah, and Yana has also posted a link into the chat as well that covers that. What dressings would you recommend for large cavity wounds?
It depends. Again, is there a lot of fluid? If there's a lot of fluid, then you need to consider what's going to wick away. So maybe a gelling fibre or an alginate or a something with silver in it if needed. If there isn't, then why not go for the HydroClean, which is going to clean it up nicely. So you have to weigh it up. I don't tend to use hydrogels in cavities because sometimes you don't know how far they're actually tracking to. Make sure you're checking and measuring if there is any undermining. Make sure you're checking if there's any sinuses, because they can be problematic.
I think we have time for one more question. So I think we'll say someone has stated here, we just use Tubigrip for compression. Are there any good recommendations / options to give to the patient?
Yeah, just be mindful when we want to achieve healing to get those valves closed within our veins. We are aiming for 40 millimeters of mercury. That's your highest level, or your class 3 of compression. To give you an idea, Tubigrip will give you 8 millimeters of mercury. So I know when I apply that, I'm not going to be helping to heal that wound. I'm simply getting the patient used to the pressure. So it's a bit of a tactful way of saying keep merging up to get you to that higher level. Now, what was the second part of that question? Sorry, Caitlin.
Are there any good recommendation options to give to the patient?
Yep, well, Hartmann has a complete range of compression that I would suggest you having a look. In terms of, is that for the patient to apply it for themselves? Then there are devices out there that they can use. Some very cluey clinicians use the plastic bag trick. I'm a wound clinician and I have no idea how you guys do it, but keep doing it. It works. So they put it on a certain way and it goes on easy. I'm not that good at it, but yeah, they would be my tips. Use a device if you can. So there's things called the Easy As, EZY As. I'm not sure if you sell them. I think you do actually at Team Med.
We do.
Easy As. Oh gosh, there you go. They actually will help that stocking. They're probably the best ones that my patients say are easy to use.
Awesome. Would you mind us jumping to the next slide?
Can.
That's okay. So just to wrap up, we have a little mini survey. If everyone can please go on, fill that out. Yana has also very kindly posted that in the chat. So please scan that. It takes 1 or 2 minutes. We will wrap up in a couple of minutes. So even if we're done, you can still do that after. But please, we want your feedback, please. I think we can maybe fit in one more question. So one I have here, is Protozan irrigation any good?
All products are as good as if you apply them correctly. So for example, Protozan solution needs to be applied and soaked on the wound for 10 to 15 minutes. Now, if you're doing that, then it will be effective. Microdacin is up to 3 minutes, and there are other products coming on the market. So you've got to weigh up what's your time allowance like.
That's great insight. Thank you, Hayley, and thank you very much for everyone joining this evening. Once again, if you could please complete the survey. Tomorrow we'll send out the PDF certificate and the recording via a link. So please keep an eye out in your inbox. And thank you, everyone, and thank you, Hayley, for being here this evening.
Thanks for the invitation. Thanks, everyone.